Okay, welcome back. We got coffee. Sophie's got coffee. Carol, hopefully, you got a snack. Ready to rock and roll. Now, I saw some questions in the chat. It's hard for me to always see the questions, but I saw your questions. Niraj wanted to know about how much iron would I give a woman? Would I give a woman 2 to 3 milligrams per day? Well, all iron deficiency is treated the same way. We're going to give you oral ferrous sulfate, about 325 milligrams, 3 times a day. 3 times a day. Because we want to fill you up. We want to fill you up. So we want to give it to you until you get your stores back up. Once your stores are back up, then we can stop it. We don't want to give you iron every day for the rest of your life. I don't want to replace exactly what you're losing. I want to fill up your stores and then let you go back on your own. Make sense? So 325 milligrams for everyone, 3 times a day, until we get your stores back up. Which reminds me, how do I know the iron treatment is working? How do I know it's working? How do I know? How do I know it's working? How am I gonna, if I'm giving you iron, you're missing iron, how do I know it's working? In 5 days, what will now appear because you gave the marrow what it needed? In 5 days, you'll see a reticulocytosis. If I fix the problem in 5 days, 5 to 7 days, you should see reticulocytosis. If you did the right thing, the bone marrow will start working. Should start pumping out red cells. And then the next thing is the hematocrit will come up, the hemoglobin will come back up, and anemia will go away. But the first thing is look for the reticulocytosis. You should 5 to 7 days. It takes 5 to 7 days, and you should be able to see it. Okay, good. All right, there was another question. Mamatha, I hope I'm saying your name right. Ask about basilic stippling. The book says basilic stippling is not specific. It's not specific. Basilic stippling is seen in lead poisoning. It's a good clue. But reticulocytes can have basilic stippling. And lots of other diseases have basilic stippling too. I've seen it with arsenic poisoning. I've seen it with thalassemia, basilic stippling. I've seen it with pyrimidine 5-nucleotidase deficiency. I mean, there's a bunch of other diseases, but for exams, we like to remember the most important ones. So when I see basilic stippling on an exam, I want to think about lead poisoning as my first clue. To confirm it, I'll get a lead level. And then I'll look for ring sideroblasts, right? Basilic stippling is a feature of lead poisoning and arsenic poisoning and thalassemia and 5' nucleotidase deficiency, not specifically mammatha. No, mamtha. Ah, I got it, mamtha. All right, thank you. Thank you so much. Yeah, such a nice name. My name is John. So boring. I like special, cool names. It's beautiful. All right, now we're up to thalassemia. Now, a couple important things. In real life, my attendings, the attendings I work with, don't know blood. Don't know. It's my opinion that a lot of family practitioners don't know blood. Every time it's microcytic, what do they think? Well, if it's microcytic, it's got to be iron deficiency. So they always miss this one. They miss thalassemia. Because in America, thalassemia is not so common. Thalassemia is common in ethnicities around the sea, Middle East, the Middle Eastern friends, all the way to Southeast Asia. That's where you see it. So in America, unfortunately, some of my clinicians, every time it's microcytic, they think it's iron deficient. They give you iron. Please tell me, what if you give thalassemia iron? They don't need iron. What if you give them iron? What are you going to cause if you give a patient who doesn't need iron? They're going to get hemochromatosis. Rena, excellent. They're going to get hemochromatosis. And I've seen a whole bunch of cases where these doctors kept treating iron deficiency with iron. It didn't get better. If the retic count doesn't go up, you're not doing the right thing. So they got hemochromatosis. Okay, makes sense? So depending on the population, your index of suspicion should go up, especially if they're from Mediterranean, Greece, Italy, Turkey, or the Middle East. I love my Middle Eastern friends. Or all the way Southeast Asia. I love the Southeast Asians. That's where you see thalassemia. All right, now let's talk more about it. This is not a problem with iron, so don't give iron. It's the alpha globins for alpha thal and the beta globins for beta thal. Without the globins, you can't make hemoglobin. So again, you'll get a microcytic hypochromic anemia, small pale cells. Now there's two types. We got alpha, we got beta. For alpha, it's a little bit more common in the Asian populations, and it tends to be a deletion. Now there are 4 alpha genes. Isn't that weird? There's 4 alpha genes. So you could delete 1, or 2, or 3, or all 4. So there are 4 types of alpha thalassemia because there's 4 genes that you can delete. Now for beta thal, things are a lot more simple. First of all, it's more common in the Mediterranean population, and it's a point mutation, not a deletion. Point mutation. The point mutation could be mild, or it could be severe. But it's a point mutation. And there's only 2 genes you can mutate. That's it. 2 genes that can be mutated. So it's a lot simpler. 2 important forms of beta, 4 forms of alpha. Wow. Now, obviously, the more genes you mutate or delete, the more anemia you will get. Okay? So obviously, the presentation depends on how many mutations and how severe you have will determine how severe it will be. All right, now let's start with alpha thal. If I delete only 1 of 4 genes, you look normal. We call you the silent carrier. Silent carrier, because look, everything's normal. Normal CBC, you don't have any anemia. Hemoglobin's normal, MCV's normal, electrophoresis is normal, iron panel is normal, everything is normal. So wait a second. Patient comes in complaining of nothing. All the labs are normal. Why are you in my office? Why did you even come in? They're silent. They're not going to come in. You're not going to know it. You'll only know it if their kids get a worse form. If they pass it on to their kids and the kids get a worse form, then you'll try to figure out who the carrier is. Okay? The only way you can diagnose this silent carrier, the only way, electrophoresis is normal. The only way you pick it up is DNA analysis. You got to look at the DNA and look for 1 deletion. It's the only way you can possibly diagnose it. DNA analysis, because everything's normal. So not very high yield for a step exam. Patient's got nothing. Okay? Now, 2 gene deletions, oh, this is the money. They love this one because somebody on this internet could have it. Yeah, it's mild. You don't even know you have it until you get stressed. When you get stressed, like you got to take step 2, or you got to fast, or you get infected, that's what's going to bring it out. Because if you mutate 2, you still got 2 left. You still got 2 left. Okay? So most people have no anemia until you add a stress, and then you come in. And it's not that bad. It's a mild anemia. Not that bad. Hemoglobin a little bit low. But what's very diagnostic here is mild anemia, but very microcytic. That's a very important clue. So the microcytosis is out of proportion to the degree of anemia. They're only a little anemic, but yet the MCV, it's not in the 70s, it's in the 60s or the 50s. MCV in the 50s with a mild, these are really genetically small cells. They're just really small. Now, one more important clue for thalassemia. Thalassemia is the only microcytic disease that has an increased red blood cell count. Increased red blood cell count. So when I count up all the cells, there's a lot of them. But wait a second, bro. Why are you anemic if you have a lot of red cells? Why are you anemic if the count is high? Why are you anemic if the count's high? Because these cells are tiny. They're tiny. They're so small you can have lots of them and still be anemic. They're tiny. There's no hemoglobin in them. They're small. So let me repeat. The only microcytic anemia with an increased red cell count is going to be thalassemia. Because these cells are so small, you can have a lot of them and still be anemic. Isn't that crazy? All thalassemia, all of them, except the silent carrier. Silent carrier is normal. Silent carrier looks normal. Okay? Now, this 2 gene deletion, we call it alpha-thal trait. Alpha-thal trait. It's mild. You don't know you have it till you get stressed. Okay, good. It's all thalassemias. All right, now 3 gene deletion. Wow, you're sick. You knock out 3, there's only 1 left. So you're going to have a profound anemia. The anemia is right here. This is not a diagnostic dilemma. This baby has anemia from birth. From birth, they have anemia. The whole life, they have anemia. All the time. And again, all of these have very slow MCVs, 50s and 60s. Really genetically small cells. The red cell count will be increased. So hemoglobin is low, but the red cell count will be high. Okay, got it. So a lot of cells, but no hemoglobin. Got it. All right, now if you delete all the genes, they die. They die in utero because they can't make fetal blood. So they die of heart failure in utero. We call this hydrops fetalis, dead, swollen baby. Very sad. So 4 gene deleted, you can't miss it. It's a dead baby. It's like, doe, dead baby, doe, dead baby, doe. Now, electrophoresis is normal for alpha. What you'll see in alpha are some abnormal hemoglobins that shouldn't be there. In other words, in 3 gene deletion, you're going to see hemoglobin H. John, I don't have hemoglobin H. Yeah, you don't have hemoglobin H either. Who's got hemoglobin H? 3 gene deletions. So we call this hemoglobin H disease. Hemoglobin H disease. It's an abnormal hemoglobin. You're not supposed to have that. Hemoglobin H, call it hemoglobin H disease. 3 gene deletion. Now 4 genes are deleted. This is called hemoglobin Bart. Doe, Bart, doe, dead baby, doe, 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 doe. Bart Simpson should be dead by now. All the crazy stuff he's done. So dead baby, doe, Bart, doe, dead baby, doe, Bart, doe. Now what is Bart's? Well, to make fetal blood, you need 2 alpha and 2 gamma. To make fetal blood, 2 alpha, 2 gamma. If there's no alpha, what's the gammas gonna dance with? Gammas there's nobody, they dance with themselves. So you get a tetramer of gamma. You get 4 gammas, which is unnormal hemoglobin. It's abnormal hemoglobin. We call it hemoglobin Bart's. 4 gammas. Remember, fetal blood is 2 alphas, 2 gammas. Fetal blood is 2 alphas, 2 gammas. If there's no alpha, you get 4 gammas. That's Bart's. That's Bart's. No! And remember Bart Simpson? Do you remember Bart Simpson? Do you remember what he looked like? Do you remember what Bart Simpson looked like? Let me see if I can draw Bart Simpson. I'll try to draw him for you. Let me see if I can draw him for you. I will try to draw him for you. Bart Simpson. Oh man, that's the worst Bart Simpson ever. Worst Bart Simpson ever. But notice the hair. Do you see the hair? He's got 4 gammas as his hair. No! No! So a dead baby, Bart Simpson, Bart's. You really can't miss that. Okay? So again, what's going to help us here is electrophoresis. Here we saw hemoglobin H. Here we saw hemoglobin Bart. That's what's going to help us here. Good. All right, now what about beta? Only 2 genes and they get point mutated. So if you get mild point mutations, you get beta thal minor. It's like the trait. It's like alpha trait. You don't have symptoms because it's mild. You don't have symptoms until you add a stress. That's why the board loves these. No symptoms till you add a stress. So you fast, you get infected, you have to take a step 2 exam, then the anemia comes out. Yeah, because only 1 gene is mutated, only 1 beta gene is mutated, and it's a mild mutation. So again, there's only a mild anemia. When they get stressed, it brings it out, mild. But again, really small, MCV in the 50s or 60s, really small. What's the count? Lots of red cells, but the hemoglobin is still low. They still have anemia. Got it? Good. Really low MCV. All right, now let's talk about the bad one. Beta thal major. They call it Cooley's anemia. It ain't cool. It ain't cool. It's a bad anemia. This is when you have homozygous severe mutations, point mutations in both genes. So basically, you're knocking all the beta out. You're knocking it out. So they're severely symptomatic. Now, it starts at 6 months because you only need beta at 6 months. At 6 months after birth, you try to make adult hemoglobin. At 6 months. Well, adult hemoglobin needs beta. So they can't make hemoglobin A. They can't make it because you need beta for hemoglobin A. So they can't make it. So at 6 months, they get severe anemia. They don't grow well. They get big liver, big spleen. They get very jaundiced. Very important. They get bone deformities, especially the cheeks, because the bone marrow's proliferating, trying to make cells, but it can't. So you get these thick bones. They look like chipmunks. Alvin! They look like chipmunks, chipmunk facial features. If you do an x-ray, you'll see a crew-cut skull. Crew-cut, because the bone's so thick, it looks like a crew-cut. Now, how are you going to treat these patients? They can't make good blood. For the rest of their lives, from 6 months on, you have to transfuse them pack red cells. So pack red cell transfusions once or twice a month. Wow, so packed red blood cell transfusions once or twice a month. Now, wait a second. Every unit is giving you a tremendous amount of iron. So what are they all going to die of? They won't die of the anemia because you're treating them for the anemia, but they'll die of secondary hemochromatosis. So they're going to die of cirrhosis because of all the iron overload, or from heart failure, because they're going to have transfusions their entire life. Very sad. So please tell me, what is the treatment of choice here? These patients are all going to die of hemochromatosis. The treatment of choice, if their bone marrow is no good, their bone marrow can't make good red cells. What is the treatment of choice here? Come on, their bone marrow's no good. There you go, Timothy. Gold star. Gold star. So for major, we want to do a bone marrow transplant. That is your treatment of choice. If you can get a donor, do a bone marrow. Because otherwise, 6 months on, they have to be transfused. They're going to die of hemochromatosis. This is terrible. So bone marrow transplant is the gold standard for this one. Only this one. Only this one. Okay? So bone marrow transplant is the gold standard. Now, if I can't get a donor, then I have to keep transfusing you every month or so, and you're going to die of hemochromatosis. I will chelate you. I'll give you chelators, but eventually they'll die anyway. Very, very sad. All right, now let's talk about the clues. The clues for thalassemia, for the traits. They like the traits. For thalassemia alpha and beta trait, it's going to be a mild anemia with really small cells. Really small cells. Okay? Now, again, whenever I say microcytic, you say iron panel. When it comes back normal, oh man, I'm thinking thalassemia. Microcytic with normal, think thalassemia. Prove it. Prove it. What would you do next? Prove it. What would you do next? The next step would be hemoglobin electrophoresis. That would be the next step. Okay? All right, now very important. A lot of doctors will just say, oh, it's microcytic. It must be iron. So let's give you iron. If you give them iron, it's not going to improve their anemia, and more importantly, they're going to get hemochromatosis. Don't give iron for thalassemia. It won't help. That's not their problem. Their problem is globins. All right, now let's talk about the diagnosis. For beta thal, we're going to look for an increase in fetal and an increase in A2. This is what we look for the traits. Okay, for trait. For major, their hemoglobin will be so low they'll need a transfusion or a bone marrow transplant. Now for alpha thal, the electrophoresis is usually normal, but you find abnormal hemoglobins. You'll find hemoglobin H for hemoglobin H disease, or you'll find hemoglobin Bart's. Hemoglobin Bart's for the hydrops, for Dallas. Okay, so for alpha, you find weird hemoglobins. For beta, you find increased F and increased A2. Okay, so alpha, you find weird hemoglobins. For beta, you find abnormalities in fetal being elevated and A2 being elevated. All right, now blood smear. Good clue, but not diagnostic. Good clue, but not diagnostic. You're going to see these. Bink, bink, looks like a bullseye. Bullseye, bullseye. Looks like a target, target, target. These are target cells. Here's the problem. Not specific. Not specific. It's a good clue. You tell me microcytic anemia with targets, I favor thalassemia, but we're still going to get the iron panel and electrophoresis. Got it? Okay. How can they confuse it if it has normal iron studies? Because they're not as smart as you, Natasha. They're not as smart as you. They're like, oh, the iron studies are kind of normal. I'll give them iron anyway. I'm serious. If the iron studies are normal, see, they don't realize they're supposed to order them. They just say you're anemic, take iron. They don't order the iron studies. They don't order them. Or if they do, they don't pay attention. I know. No, sir. When you know your stuff, you're as good as the hematologist. Give yourself credit. Seriously, most doctors don't know blood. And blood is easy. But most doctors don't know it. You do. That's awesome. All right, now remember, RDW is normal because they're genetically small, but they're all small the same. They're all small the same. All the cells are the same size small. So the RDW is normal. Remember, iron deficiency, it was sky high. Thalassemia, it's normal. All right, now let's talk about treatment. For the traits, they don't need treatment. Avoid stress. Avoid stress, but very important. Know who you marry. Genetic counseling. If you get stressed, you get anemia. Then it'll go away. No big deal. But if you marry somebody else with a trait, your kids could have worse forms. So remember, genetic counseling. Genetic counseling. They like that, especially on step 3. Make sure you give the genetic counseling. Now, beta thalassemia major, Cooley's is a big problem. So again, if we don't have a bone marrow transplant, that's the gold standard. We'll transfuse you once or twice a month. We're going to give you folic acid because your cells are turning over, turning over. Whenever there's cell turnover, give a lot of folate or you'll run out. And then, because of the chronic transfusions, you're going to get iron overload. So to prevent the hemochromatosis, we used to use the IV one, deferoxamine, but this requires IV or a subcutaneous pump. Nobody wants IVs or pumps. So now we're doing the new oral agents. Now this is a big deal. This is a super big deal. So when we want to treat hemochromatosis on step 2 and step 3, we prefer the oral agents now. They're new and sexy. But notice they all start with D-ferra. See that? D-ferra, D-ferra. They're all D-ferra. This one was IV, so that's the old one. The new ones are oral. Deferricerox and deferriprone. Deferricerox, who the heck invented this name? Deferricerox. It sounds like a dinosaur. Have you seen the Deferricerox Rex yet? The Deferricerox Rex. Yeah, it's a pretty bad dinosaur, right? Who's making these names up? But anyway, these are sexy and new oral chelators. They've only been in the last 10 years. So these are pretty darn cool new drugs. They're oral. People like to take oral. They don't like needles. So this is pretty hot. But again, it's not the gold standard. The gold standard is a stem cell transplant. That is the treatment of choice for beta thal major. Okay, it's the only chance at cure. If I don't have a bone marrow, then I got to transfuse and chelate. Okay, good. Now, a splenectomy is one thing that can be done because splenectomy is an area where cells get destroyed normally. So if you slow down destruction, your anemia won't be so bad. So if they have a lot of transfusions they need every month, we may do splenectomy to decrease the hemolysis, and that way you don't have to transfuse as much. But please tell me, before splenectomy, what must be given? Before splenectomy, what must be given, doctor? Before I take a swing? Vaccinate. Pneumovax. Haemophilus influenza. And then don't forget about the vaccines, Neisseria meningitidis. So 3 vaccines. Pneumovax, meningitis vaccine, and Haemophilus vaccine. Encapsulated organisms. Okay, so that's very important. Before your splenectomy, if you can, get the vaccines on first. The encapsulated ones. Excellent. Encapsulated. Ron's right. Asthma got it. Asthma? I hope I'm saying your name right. Asthma. Excellent. All right, now let's try this out. Macrocytic. Well, macrocytic could be megaloblastic, could be alcohol, could be drugs, a lot of things. So a 72-year-old alcoholic, it could be alcoholic, comes to the office with weeks of memory loss, tingling in his feet. Tingling, neurologic, he's got neurologic stuff, and hematocrit is low, he's got anemia, and his MCV is 110. Macrocytic, neurologic, macrocytic neurologic. Yeah, we certainly have to think about megaloblastic anemia. Think about megaloblastic. Now, do you remember what I do first? I quickly look at the blood smear because we always order CBC and a blood smear. CBC and a blood smear. Look at the blood smear real quick for hypersegmented neutrophils because that would really help you. Because again, it could just be the alcohol. Could be the alcohol. Okay, but with the neurologic, you start thinking B12. All right, now let's talk about the macrocytic anemia, the megaloblastic anemias. Vitamin B12 and folate, very testable on the exam. All right, now why do you get B12 deficiency? Well, it could be absorption problem, very common, absorption. Intake, not so much. B12 is in meat. To get an intake problem, you have to be a strict vegetarian, and it would take years. It takes years for B12 to run out. Okay, so it's more likely absorption. Absorption is more likely. And notice it gives you 2 problems. It gives you anemia and gives you neurologic. So that's a very important clue. It tells her from folate. Folate doesn't get neurologic. All right, now the most common cause of B12 deficiency in the United States, most common, always know most commons, is pernicious anemia. Pernicious, gotta know it. Pernicious anemia. It's an autoimmune gastritis. You're making antibodies against your parietal cells and against your intrinsic factor. Without intrinsic factor, you can't absorb B12. B12 has to have intrinsic factor or it doesn't get absorbed. Now, another cause would be a gastrectomy or an atrophic gastritis. Whenever you don't make intrinsic factor, you can get it. But again, pernicious anemia is by far the most common cause in America. Now, I love my Indian friends. When I go to India, they say, John, we have a lot of vegetarians here. They don't eat a lot of meat. Oh, so in India, vegetarianism is a big problem with this, right? But in America, not too many vegetarians. In Chicago, everybody's eating meat. I'm walking out, everybody's eating meat all over the place. Okay, maybe in LA a lot more vegetarians. But in general, in the United States, we're a bunch of meat eaters. So pernicious anemia is the most common cause. Okay, but my best friend's from Madras, and she tells me that in India, diet is a problem. Now look at this beautiful picture. This is a stomach biopsy, and I stained it with antibodies against parietal cells. Do you see all these little cells, these round things? These are the cells. You can almost imagine the nucleus in the middle. See the nucleus in the middle? These are all the parietal cells. This is staining the antibodies to the parietal cells. Look at all these antibodies depositing around the parietal cell, depositing around the parietal cell, depositing around the parietal cell. These are all the antibodies just lighting up because they're all attacking it. So this is a stomach biopsy with lots of antibodies against parietal cells. So this is pernicious anemia. All right, now, malabsorption. You can also get malabsorption because of the ileum. Ileal disease. Because the ileum is where you absorb it. So what was inflammatory bowel disease? That skips around, but the most common site's the term ileum? Crohn's, also known as regional enteritis. So they love Crohn's disease giving you B12 deficiency because it loves the ileum. Okay? Sprue can involve the ileum, especially tropical sprue. Now, blind loop syndrome can do it because the bacteria can eat the B12. If you have a blind loop, you had surgery, you have a blind loop, bacterial overgrowth, the bacteria will eat your B12, and you won't get it because the bacteria will eat it. Another organ you should know about is the pancreas. Pancreas. Without the pancreatic enzymes, you can't free B12, and it can't get absorbed. So I need the pancreas. Anybody with pancreatic damage, like alcoholics or cystic fibrosis patients, they destroy their pancreas and they get B12. So remember that for the exam. Alcoholics because of pancreatitis and cystic fibrosis because they destroy their pancreas as well. Oh, they like this one. Do you like sushi? If you eat sushi like I eat sushi, you might be worried about this. The fish tapeworm, Diphyllobotham latum. Yeah, it'll eat your B12, man. It loves to live in there. It's from sushi, uncooked fish, uncooked fish. Now, again, it's rare, but it certainly can occur, especially on exams. Diphyllobotham latum. All right, and finally, intake, like vegetarians, it would take years. Take years. Vegetarian for years, you got a chance of getting this. All right, now again, the symptoms are anemia. Anemia. The anemia symptoms are all the same. Doesn't change. The more severe it gets, the more anemic you are. But you can't diagnose it with the symptoms. Can't. So what's going to help me here is the neurologic. Here's what I want you to remember. Any neurologic symptom under the sun. Most commonly, wrist drop, foot drop, sensory. That's most common. But any neurologic. They can get anything. They can get peripheral neuropathy. They can lose the position sense, vibratory sense. They can get psychiatric, autonomic, motor, cranial nerve, blah. You can get any neurologic symptom in the book from B12. Any single one. Okay, again, mostly it's wrist drop though and sensory. All right, to pick this one up for diagnosis, we're going to see the MCV increased. Okay. You'll look for neurologic. Okay, you could have neurologic without anemia. Okay, but usually they're together. Now let's take a look at the blood smear. You're going to look for hypersegmented neutrophils. Now if I look at this one here, it looks like 1, 2, 3, 4 segments. Okay, that looks pretty good. This one's got 1, 2, 3, 4, 5, 6. Listen, if you see more than 5, that's B12 and folate. More than 5. Okay? No doubt about it. So more than 5, that's hypersegmented. It's B12 and folate. All right, now, what else are you going to see in terms of red cells, though? Well, they're very big. They're very big. And look at this. They're not round. They become oval. Circle that and star that. Macro-ovalycytes. Listen, alcohol gives you big red cells, but they're round. Drugs, big red cell, round, round. Liver disease, big red cells, but round. These are big and oval. So again, there's 2 important clues here. I see anemia with big oval red cells and hypersegmented neutrophils. Good. All right, so look for those oval macrocytes, those red cells, because all the other causes, hemolysis, liver disease, alcoholism, myelodysplasia, they give you round macrocytes. So look for the oval ones for B12 and folate. All right, now reticulocyte count is reduced, but sometimes it can be elevated. I've seen cases where it's elevated, so forget the retic, not really going to help you. But what's going to help you is in the marrow. The marrow is very hypercellular because you're trying to make cells. But without B12 and folate, they stay there a long time to mature. It takes them a long time to get enough DNA. So they stay there a long time, and your marrow becomes very hypercellular. Okay? All right, now here's a good important thing. When you try to make a red cell, they often get destroyed if they stay there too long. So they often have a lot of red cell destruction, which means LDH goes up. Anytime you destroy a cell, LDH goes up. They often have higher bilirubin. Okay? So often the iron is elevated, the ferritin is up because of inflammation, acute phase reactant. But these are all non-specific features. We can see this with any hemolytic anemia. Any hemolytic anemia can give me this. Okay, so not specific. I don't want to waste time on things that are non-specific. I want specific. Here's specific. The best test to start with is a B12 level. What? Yep. How do you diagnose B12? Low B12 level. Brilliant. Brilliant. Now, what do students say? They say Schilling's. For diagnosis, B12 level. Now, here's the bad news. B12 is an acute phase reactant. So if there's inflammation, it may be falsely elevated. So if it's low, I know there's B12 deficiency. If it's normal, it could still be B12 deficiency because of acute phase reactant. So I would get next, if it's equivocal, I would get methylmalonic acid levels next. So let me repeat. If it's low, you're deficient. If it's normal, but it smells like it, they got the neurologic, they got the megaloblastic, they got the hypersegmentation, but the B12 is normal, but I think it is. Get methylmalonic acid. That's your next test if the B12 level is equivocal. You're not sure? Get methylmalonic acid. Okay, that's your second test. They love this kind of stuff on a step 2. They love it. Now, what is the best test to prove etiology? Well, it used to be the Schilling's, not anymore. Since the most common cause is pernicious anemia, get the antibodies. Get the antibodies against intrinsic factor and parietal cells. That's the best test for etiology. Get the antibodies. Got it? So for diagnosis of B12, you get a level. For etiology, you get the antibodies. That's how you'll prove that it's pernicious anemia. Now, Schilling's test is rarely used anymore. Rarely used. Especially when I got the antibodies. Got the antibodies, I don't need it. I don't need it. But of course, you know the USMLE. Are they going to give you a Schilling's test? Yeah, even though we don't do it anymore. So let's just talk really quickly about the Schilling's. Let me switch over here. Oh, wow, cool. Oh, excellent. Insulinomas, very nice. Oh, Cushing's, very nice. You guys did some fun stuff, right? Okay. Yeah, if antibodies are equivocal or antibodies are negative, well, then we'll do Schilling's next. Schilling's would be the next step after the antibodies if they're equivocal. Now, Schilling's, here's the key. Schilling's test is not going to work if there's an absorption problem. So if there's a problem with your stomach or your pancreas or your ileum, it's never going to work. I give you radioactive B12, you can't absorb it. So let me repeat. Schilling's test is always abnormal if there's a problem. Okay? So if I do the Schilling's test and it's abnormal, there's a problem. There's something wrong with your stomach or your ileum or your pancreas. So if Schilling's is abnormal, there's a problem. Then we're going to do it again. We're going to do the Schilling's test again and see if we can fix it. Whatever fixes it will tell us what the problem is. So let's do the Schillings again. I'm going to give you radioactive B12. Okay, no, I started at the beginning. I should start at the beginning. What is a Schillings? I give you radioactive B12 and see if you can absorb it. You're normal. Could you absorb it? Yeah, you can absorb it. Then you'll pee it out and your urine will be radioactive. If your urine is radioactive, that means you absorbed it, you're normal. That's a normal Schillings. If you have pernicious anemia, I give you radioactive B12, what happens? I can't absorb it. So my urine will be negative for radioactivity. You didn't absorb it. There's something wrong. So if I give you B12 and you don't absorb it, that's an abnormal Schillings. Give you B12, you didn't absorb it. Now let's do it again. I'll give you the B12, but this time I'm going to give you intrinsic factor. If I give you intrinsic factor and it becomes normal now, the Schillings is normal, oh, you must be missing intrinsic. So here's what I'm telling you. Don't fear the Schillings. Whatever fixes the Schillings is what you're missing. Let me do it again. Schillings is abnormal. Then I do it again with intrinsic factor and it's still abnormal. It's still abnormal? Huh, okay. Let's do the Schillings again. And this time I'm going to add pancreatic enzymes. I'm going to add pancreatic enzymes. Okay, I add the pancreatic enzymes and now it's normal. What's the problem? I gave you pancreatic enzymes and you fixed the Schillings? You must have something wrong with your pancreas. You have chronic pancreatitis. Either you got an alcoholic, you destroy your pancreas, your cystic fibrosis, you destroy your pancreas. Something's wrong with you. Got malabsorption. Something wrong with your pancreas. Good. Let's try it again. Schillings test is abnormal. It's a new patient. I do it with intrinsic factor. It's still abnormal. I do it again with pancreatic enzymes. It's still abnormal. All right, I do the Schillings again, but this time I add an antibiotic, a broad spectrum antibiotic, which is going to kill lots of bacteria. All right, if it becomes normal now, well, became normal antibiotics, I think you got bacterial overgrowth. I think you got too much bacteria in there. I think you got a blind loop syndrome. Think you got blind loop? Got bacterial overgrowth. Got too much bacteria in there. So blind loop. Blind loop is the answer. Too much bacteria. All right, now question. What if everything is abnormal? Everything. Abnormal, 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 abnormal. Then it's the terma ileum. Terma ileum. Got it? Don't fear the Schillings. If Schillings is abnormal, there's absorption problem. If Schillings get better with the intrinsic factor, it's the stomach. If Schillings get better with pancreatic enzymes, it's the pancreas. If Schillings get better with antibiotics, it's bacteria. If nothing makes Schillings better, it's the terma ileum. Got it? Catherine, you're awesome. Hey, Zainab, I know you. You're my other class. Hey, wait, hey, how are ya? How are ya? So nice to see you again. All right, so this is so much fun. Schillings. In real life, we never do it. But on the exam, they love to do stuff like that. You guys are with me still? I hope you're with me. You're very quiet. This is a very quiet class. All right. Schillings test. Maybe I went too fast. All right, now let's talk about treatment. How you gonna? Oh, we're always gonna give you B12. Let's give you B12 in the muscle. And by the way, you feel really good. B12 injection, you feel so good. Give them the B12 intramuscular injection. They feel so good. Now, if you give folate and it's B12, if you give folate for a B12 deficiency, the anemia will actually get better, but the neurologic won't. The neurologic won't get better. You're going to mask it. Make sense? So if I give you folate and it's really a B12 problem, the anemia gets better, but the neurologic won't. And listen, neurologic symptoms, the longer they're there, the more likely they are to be permanent. The longer the neurologic, the more likely it is to be permanent. So if I just give you folate The patient will feel better. Their anemia gets better. But the neurologic will persist, and then over time it will become permanent. So always don't miss B12. Got to replace B12 if it's B12. All right, so far so fun. Let's talk about this. Always watch for hypokalemia with B12 treatment. Why? Because when I give you B12 and you're missing it, you're going to make cells like crazy now. You're going to make them like crazy. You're going to make them like crazy. You're going to make them like crazy. When you make cells like crazy, you can get low potassium because of the rapid production of blood cells. Okay, so very important that you have to watch for hypokalemia when I treat B12. The retic count will jump up right away. All right, now let's compare this to folate. Folate deficiency. It's a deficiency of folic acid, and that's going to lead to another megaloblastic anemia. Now, this is usually due to diet. For instance, alcoholics, they only eat alcohol. The elderly, they eat tea and toast. Remember, folate is in green, leafy, uncooked vegetables. So alcoholics don't eat salads. Elderly don't eat salads, they don't have teeth. So unfortunately, elderly and alcoholics are at big risk for this. Now, pregnant women are at risk because the baby's going to take it, right? And if she becomes deficient, the baby can get a neural tube defect. So pregnancy. Eczema. Whenever you have an exfoliating dermatitis, you're losing skin, you're losing folate. Whenever there's cell turnover, make sure you give folate. All right, you can have increased loss of folate because of dialysis. You lose folate through the dialysis machine. And of course, phenytoin gives you folate deficiency as well. Now, presentation, it's anemia. Just anemia, no neurologic, just anemia. Okay, for diagnosis, you'll never guess. You'll never guess. Folate level. Red blood cell folate level. That's how you diagnose it. I know. So again, it's going to present the same way. It's going to be anemia with a high MCV. You'll see hypersegmented neutrophils just like B12. So then you get the red blood cell folate level. You make your diagnosis. Give them folic acid, oral folic acid, and treat the cause if you can. Treat the cause. All right, now, megaloblastic is done. We're going to go to the third category, which I think is the most difficult. For step 2, I think it's the most difficult category. Microcytic, straightforward. There were 4 big ones. You get the iron panel, easy. Megaloblastic, B12 and folate, everybody kind of knows it from step 1. But hemolytic is a whole different ball of wax. Hemolytic, remember, high retic, normocytic anemia with high retic. And there's a lot of different causes of hemolysis. So I think this is kind of a difficult one. So let's go through this in good detail here. All right, hemolytic anemia means you're destroying your red cells faster than normal. You're breaking them down, so you're basically destroying them. Now, 2 places they can get destroyed. They can be destroyed inside your vessel, that's intravascular within the blood vessels, or it could be destroyed extravascularly outside the blood vessel. Usually it's in the spleen or the liver. Spleen and liver, that's extravascular. Now, an important point here. If it's intravascular, you're going to release hemoglobin. So what's in your blood that binds hemoglobin so it doesn't get lost? Does anybody remember what captures free heme? Captures heme? Haptoglobin. Haptoglobin will try to scavenge it. So the haptoglobin will grab it and then be removed. So a good clue for intravascular is you have really, really low haptoglobin levels. Really low haptoglobin. That's a very important point. Number two, any hemoglobin that escapes that will go into the urine, and what cell is going to eat it? What cell is going to try to reabsorb it in the urine? What cell is going to try to reabsorb it? The proximal tubule cells. They're going to try to pick up the heme and the iron so you don't lose it. So the proximal tubule cells can absorb it, and then question, what's going to happen in a couple of days? Well, they're going to die and fall off. And now I'm going to see the iron that was stored as hemosiderin in the urine. So now I'm going to see hemosideruria. Hemosiderin in the urine. Hemosidenuria. So hemocydin in the urine. Now this takes a few days. Takes a few days because the peroxidal tube has to absorb the iron, and then a few days later it dies, and you'll see hemocydin in the urine. Now more acutely, you'll see hemoglobin in the urine. Hemoglobinuria. Okay? So let's repeat. When you get intravascular, you're breaking the red cell, you're releasing hemoglobin. Haptoglobin will try to scavenge it. Haptoglobin will go down. Once it's overwhelmed, hemoglobin will be lost in the urine. Hemoglobinuria. After a few days, the peroxidal tubular cells that try to reabsorb it will die, and you'll see hemocydin in the urine. Okay, got it? Very important. And by the way, is this stuff toxic to the tubules? You bet. If it's really severe, you can get acute tubular necrosis. So you got to maintain renal function. Be very careful here. Renal can get damaged. Now, extravascular is not much of a problem with that because it's being destroyed outside. So it's usually going to have splenomegaly or hepatomegaly, but usually splenomegaly. Get a big spleen. Okay, haptoglobin's not going to go down so much. You're not going to see hemoglobin in the urine, and you're not going to see hemocydin in the urine either. You're not going to see those things. So you're just going to see a big spleen and a lot of jaundice. All right, now, it could be a chronic hemolytic anemia, or it could be an acute hemolytic anemia. Chronic things like sickle cell, you have that your whole life. Paroxysmal nocturnal hemoglobinuria, hereditary cirrhosis. This is chronic. You have it all the time. Hemolysis all the time. Or you could get acute episodes. So you take a drug, you get hemolysis. Or you can have an autoimmune episode, a flare of autoimmune, and you get hemolysis. Or you eat fava beans, and you get hemolysis. Yeah, this is going to give you dark urine because of hemoglobin, right, being released. So again, it could be a more chronic disease, or it could be a more acute disease. Okay, good. Now, hemolysis is usually going to be the answer when the anemia onset is sudden. Sudden. Remember, I told you, acute onset, think about hemorrhage and hemolysis. Acute onset, hemorrhage and hemolysis. Hemorrhage, blood loss, and hemolytic anemias. They have acute onset of anemia. Number two, when I break a red cell, I'm going to make a lot of bilirubin. So that's going to create jaundice and dark urine because of the breakdown of the red cells. And if it's really acute, you often get fever, chills, chest pain, tachycardia because of the rapid hemolysis. All the hemoglobin, the free hemoglobin in your blood causes all these symptoms. Basically, it's systemic symptoms from rapid breakdown. All right, now, how are we going to diagnose this? Well, number one, they're going to have anemia, but it's normocytic. Well, whenever I say normocytic, so it's 80 to 100 MCV. Well, the next step is always going to be the retic count. Get the retic count. It's going to be high. So here's the key. Normocytic anemia with a high retic count. Normocytic anemia with a high retic count. Immediately, you got to think about hemolytic anemias. Okay? So normal MCV, get the retic count. All right, now, whenever cells break down, LDH goes up. Bilirubin goes up, and it's unconjugated. So indirect is going to be elevated. That's unconjugated. Yeah, it's usually sky high. So again, LDH is up because of the lysis, and bilirubin's up because of lysis as well. And that doesn't matter. Intravascular, extravascular, they both have that. Now, peripheral blood smear is often very helpful here because if you see sickle cells, if you see spherocytes, spherocytosis, you got to look for some clues here. So peripheral smears are often very helpful. Very helpful here, peripheral smears. All right, now we talked a little bit of haptoglobin. It tends to be low with the intravascular, not so much extravascular. Hemoglobin is often present in the urine with the intravascular as well, hemoglobinuria. And why is there no bilirubin in the urine? I want to know that. Why is there no bilirubin in the urine? Why? Yes, David, you're correct. David, you're right. Why is there no urinary bilirubin? Because it is unconjugated. Unconjugated is not water soluble. It can't get out. So unconjugated indirect is bound to albumin and it's not filtered. So that's why there's no urinary bilirubin. Hemoglobin, yes, but no bilirubin, okay, because it's water soluble. And as I mentioned, you can have hemosidenuria. Hemosidenuria after a couple of days. And that usually occurs with intravascular, but it takes a couple of days. Okay, it's a couple of days to see it because it got to be shed. All right, now all hemolytic anemias may require a transfusion if the hematocrit gets low. So if it's less than 8 or less, we transfuse. Again, if there's heart disease, you want to transfuse and keep it over 30. Okay, so transfusion may be required because these cells are being destroyed. Now, very important to hydrate. We talked about this being toxic to the kidney, so make sure you give a lot of fluids here so you don't get tubular injury from all the hemoglobin. Therapy. The cause is the key. If it's sickle cell, different treatment. You got to know the cause here. So we got to figure out the cause, and then we'll figure out how to do the specific treatment. Now, here are the big ones for your exam. The big hemolytic anemias. They love sickle cell. They love autoimmune. They like hereditary. Every once in a while, they're asked about PNH, and then, of course, G6PD. Okay, so these are all pretty much high-yield information. So let's start. Oh, no, wait. First, we got to take a break. Man, that hour went so fast. Didn't it go fast? I look at the clock and I'm like, oh my gosh, it's after 8 already. Man, it goes so fast. When you're having fun, time goes fast. So we'll take a break and then we'll go through all the different hemolytic anemias. Okay? I'll see you guys in 10 minutes.